Dr. Alan Courtney is one of the principal clinical scientists here at Imperial College as well. He leads the protein lab, and he's kindly going to talk today on protein electrophoresis and its use in diagnosing hematological disorders. Thank you.
Good afternoon, everybody. So I'm going to give you a brief run through of some of the guidelines around sort of myeloma screening, the role that protein labs, particularly how our lab functions for providing electrophoresis service. And then I'm going to touch on the use of free light chains, particularly sort of how they should be used and what the actual results mean. And probably I'm also going to go on and touch on something which has become a little bit more of a common issue in laboratories, is basically switching from BJP testing onto free light chains. So when we think of a paraproteinemia, we're thinking about basically an increased production of a single monoclonal immunoglobulin or immunoglobulin fragment. And this gives rise not just to myeloma, but quite a diverse group of potential disorders. And when we think about the role the laboratory plays with respect to electrophoresis for the diagnosis of myeloma or for paraproteinemia, we basically take the role of detecting these paraproteins, typing them, and also quantifying them. So in a healthy individual, you'll have your plasma cells here. And each plasma cell will basically produce immunoglobulins or your antibodies. And in addition to that, they will also secrete a small quantity of free light chains. So following clonal expansion of a plasma cell, you can give rise to a small monoclonal protein. And typically, these will start all as an MGUS state, so monoclonal gammopathy of unknown significance. For a relatively small percentage of these will go on to develop into a full paraproteinemia. And in particular, when we're thinking about this, the questions we'll often come up with is relating to multiple myeloma. And you've got three main sort of potential types of myeloma. You can have your intact immunoglobulin. So we've got a secretion of intact monoclonal antibodies here. And this accounts for roughly about 80% of myeloma cases. We then have clones which only produce free light chains, and this accounts for roughly about 20% of case of myeloma. And then we have a small, a far smaller group which are non-secretory or possibly oligosecretory, which may secrete small quantities, very small quantities of excess free light chains. We also potentially have amyloidosis patients, and this is where your free light chains will become deposited as fibrils in tissues, particularly, say, the heart and the kidney. So the presenting clinical features of myeloma can generally be remembered as the acronym CRAB. So we've got our hypercalcemia, an impaired renal function, anemia, and bone disease. And quite typically, early sort of cases of myeloma will show clinically with an anemia. And it's obviously, this is the sort of thing to look out for and consider. We also have two other possible presenting clinical features, which are recurrent bacterial infection and the presence of hyperviscosity. So we're thinking about the different types of myeloma. We can type these in the laboratory, and approximately about half of all the paraproteins and half the myelomas that we see tend to be your IgG paraproteins, and these are by far the most common. We then have our IgAs, which account for around about a fifth. Far less commonly in respect to myeloma, there's a very small number of IgM myelomas. There are around about 10% of all paraproteins. And then we have the far less common rare types of myeloma, which would be your IgD and IgE types. So the key thing here to remember is that you won't always get a paraprotein detected on your electrophoresis. So you will often see around about a fifth of cases being BJP only, where you've got your secretion of free light chains. And again, there are the sort of more difficult ones to pick up, which are the non-secretory myelomas. So I think one of the things to focus back on is to think about this also from the patient side of things. So a lot of this data which I've got on this slide comes from Myeloma UK. Myeloma UK is a pretty good resource these days for looking at altogether guidance for both patients and clinicians. And approximately around about 6,000 people per year are diagnosed with myeloma, with around about 24,000 living with myeloma in the UK. So the time to diagnosis is as much as approximately sort of 163 days on average given here. And 25% of the total number of patients, it takes over 10 months for them to be diagnosed. Unfortunately, and this is where we'd like to try and improve things, around about 31% of patients are diagnosed by an emergency route where they are presenting clinically. And you can often trace this back and you can see potential delays with patients maybe being seen by GP up to 3 months earlier. So in terms of how we want to think about a pathway, it's important for us basically not to miss patients and to use the data we have, but also to process things in an efficient way as possible from a laboratory side of things. And there's been a variety of studies which have looked at the impact of a delayed diagnosis, and it has been reported that this affects outcome and including an effect on quality of life. A lot of patients have never even heard of myeloma. I mean, when people ask me what I do for a job, I tell them, I work in a laboratory, we do all this testing, and I go on and I mention myeloma. Most people look at you with a complete, what on earth is that? So a lot of patients, they come in, they've never heard of it. There's a lot of anxiety about it, especially when they're told that it's non-curable. And it's important to take on the sort of patient's experience within any sort of diagnostic pathway which we come up against. So there were, the last time I think NICE published guidance on laboratory investigations for myeloma, it was back in 2016, and NG35, if anyone wants to go and look it up. We basically use, as an upfront standard test, we've got serum protein electrophoresis and serum free light chains. So the serum protein electrophoresis is typically done in most large laboratories these days by capillary zone electrophoresis. I'm not really going to talk through any of the methods, but you can go away and obviously look those up. The use of gels is tending to be phased out now, and it would only be the preserve of smaller laboratories to stick with the gels for the upfront electrophoresis assays. The serum free light chain assays, there are different assays on the market. The most commonly used one is probably the binding site assay. It's worth bearing in mind that the different free light chain assays will give you different results, and it's often due to the different types of antibodies which they employ within their immunoassays. To confirm any of the findings on protein electrophoresis, we would then do serum immunofixation, and these are all done as gel-based assays. And the key thing, one of the key things from the guidance is not to use any of these assays in isolation. And in terms of an assessment of prognosis, one of the recommendations is to use the free light chain assay, in particular to look at the free light chain ratio, or I would say more commonly these days, especially within the hematological clinics, is to look at the free light chain difference. So rather than the ratio between your kappa and lambda light chains, just to look at the difference between your kappa and lambda light chain concentrations. We also have the BSH guidance, which has been incorporated into some of Myeloma UK's website. And this was updated relatively recently in 2001. They go a little bit further with their recommendations, and they now tell everybody not to use BJP as it has a limited use, but it still says, you know, it may be useful in clinical trials or research projects. And there may be the occasional patient which it may give some benefit to, but as a frontline diagnostic or screening tool, it's not recommended. They also give further information around the use of free light chains particularly as a tool to assess light chain production and response to treatments, light chain only myelomas, and also some recommendations around sort of oligoclonal secretory, non-secretory disease. They also go on to suggest that all free light chain assays should use a renal reference range. So where you have renal impairment, you can have retained light chains, and so you will have higher concentrations of kappa and lambda. And they also, as with the NICE guidance, suggest the use for both monitoring asymptomatic and symptomatic myeloma. So within our laboratory, these are sort of like the frontline sort of tests which we should consider. In particular, in the protein lab tests, which I will basically concentrate on, we're going to look at serum protein electrophoresis, a little bit on urine protein electrophoresis, and mainly also focusing around serum-free light chains. To establish diagnosis, I said confirmation of your findings by immunofixation, and also in terms of looking at the tumour burden and prognosis, we can also quantitate our monoclonal M protein and also measure beta-2 microglobulin as well as our free light chain assay. So this is what a serum electrophoresis trace from a CZE analyzer looks like. You'll have a separation of, separation into your various protein fragments, albumin being separated from your alpha-1, alpha-2 proteins, beta-1, beta-2, and gamma globulins. So there's all different sorts of proteins which can separate into these regions, and potentially your paraprotein could be found within any of these regions, but most commonly you're going to see paraproteins found in the gamma region and possibly the beta region. If this is a serum immunofixation of a healthy individual, so there's no obvious paraprotein detected here, but we can see, I'll show you some abnormal ones in a minute. So there are also, in addition to potentially finding any paraproteins, you can have a variety of different serum electrophoresis patterns. You can have increased gamma globulins, as shown in the first figure here, figure 1, and you'll see an increased polyclonal peak here. This, again, is a fairly non-specific finding, but stereotypically or classically, you might find this associated with things like general inflammation or possibly a liver disease. You've got, in the second figure here, we've got increases in alpha-1, alpha-2 globulins. Again, fairly non-specific finding, but tends to be associated with an acute phase response. And then we've got something which the third figure here is something we very commonly find in patients who are either presenting in outpatients or particularly GPs, where you've got, again, a general sort of inflammatory pattern, which could be related to a number of different conditions. And this often will coincide with mildly increases of either IgA immunoglobulin or potentially IgM. But classically here, you're not going to see a paraprotein. This is just a polyclonal increase of those immunoglobulins. We've got in figure 4 nephrotic patterns, so you've got a decreased amount of albumin present here. The rest of these will look slightly elevated, but actually if you take into account the reduced protein, often we'll see these as very flat patterns. And in the 5th and final one here, we've got a decreased gamma globulin region here, so potentially a suppression of our immunoglobulins. So where we have got paraproteins, I mean, this is something you might see with a fairly small paraprotein, but it's a discrete paraprotein, probably around about sort of 5 or 6 grams per litre. In these cases, we would use our serum electrophoresis. We've identified that as a possible peak. And then we're going to do our immunofixation. And you can see on this gel where we've got our antibodies to our immunoglobulins IgG, A and M. There's a small band within the IgG, and there's also a small band within the lambda. So we would type this as an IgG lambda paraprotein. For larger paraproteins, we don't need to use sort of like the manual gel approach, and the use of gels is quite time consuming. You basically need probably around a few hours by somebody in the lab to actually run the assay, and then it needs to be manually interpreted and then reported. With our onboard serum immunotyping subtraction methods, which we've got on our CZE analyzer, these effectively use the antibodies to remove associated paraprotein peaks. So anywhere you have an excess, you are subtracting everything. So in this case, we are seeing a decrease when we've added our IgG antibody prior to loading it through the gel. We've got a decrease in total IgG here, which you can see from the peak. And similarly here with the kappa. So again, this paraprotein would be typed as a IgG kappa. It's a very quick method to put through. We can process an array of samples pretty much within sort of say about 45 minutes to an hour, and then we can get these reported. And these are more likely to be the more significant paraproteins to be detected in a laboratory setting. So when we're typing our paraproteins, why are we actually typing them? So the different types of paraprotein will have different implementations in terms of what we then go and think about from a diagnostic pathway and whether or not they need to be referred to oncology. So with our IgM paraproteins, we can try and look at whether or not these are significant or not. And we have a different criteria based around your IgM versus your IgG or your IgA. And I'll show you later on in one of the slides, we've got an algorithm which we have produced particularly for advice for our GPs. So we quantitate all the paraproteins by very simply using an area under the curve relative to the total protein. So your total protein method will contribute a fair amount of error to your quantitation. So just bear that in mind if there are any issues with your total protein method within your auto lab, but most methods are fairly robust. And there is actually fairly little variation amongst well-trained staff when they're actually looking at the area under the curve. So we would demarcate either side of this paraprotein and quantitate it. There's probably a variance of around 1 to 2 grams per litre, just to give you an idea of what the sort of uncertainty is. So one of the other common things we see in the laboratories, we see these sorts of patterns where you're going to have multiple paraproteins. And they're all relatively small paraproteins, often either undetectable or the quantitations are too low to quantitate accurately, so they tend to be less than 2 grams per litre. And you can see when we've run this sample on immunofixation, you've got several different types of paraprotein there. So there's IgG kappas, IgG lambdas, IgM lambda paraproteins. And these are quite common patterns that we get in patients which have got altered immune states, so HIV patients, for instance, liver disease, or any other sort of systemic sort of inflammation. So again, these are sort of relatively low risk type patients, and we would usually just, unless they've got any sort of other clinically presenting symptoms of myeloma, or they've got substantially abnormal free light chains, we'd usually just recommend that they have a follow-up after 3 to 6 months. In terms of some of the other patterns, when we have particularly where we have low immunoglobulin levels, we would tend to always do immunofixation on these patients. And we would also always check their free light chain levels. So there's always a risk with these sorts of patients that they could potentially be light chain only or non-secretory myeloma where they've had a suppressed immune system. So these are the sorts of ones to watch out for. They can slip through the net. And the other very common question I got asked, I don't know how many times over probably the last 10 years I've been asked this question, is what do we do with high globulins? So it's really a case of how long is a piece of string. But we went away and we actually did look at this and did a clinical audit. So increased globulin levels are a fairly non-specific marker, and they would tend to be far more commonly associated with inflammatory responses and immune disorders. But they can obviously, as part of that, be related to paraproteinemia and myeloma. So we looked in both GP and in our inpatient and outpatient populations, and we came up with sort of two sort of generalized targets. So what we saw was that you are more likely to have a paraprotein in a population, a GP population where it's greater than 40 grams per litre. However, it's still, all the paraproteins that we generally pick up here tend to be fairly sort of small paraproteins, are less than 10 grams per litre. The ones where they're far more likely to be significant and where there's a more significant increased risk of a significant paraprotein would be where we see globulins greater than 50 grams per litre. So in these cases, we recommend that electrophoresis and free light chains are basically done if they've not previously been done in the last 3 months. And we have a similar sort of thing for inpatients and outpatients. Again, just because of the type of patients that we're seeing, we've got a slightly different globulin target for this, which is 60 grams per litre. And we have this set up as an automatic reflex to do our protein electrophoresis on these patients. So there's quite a few limitations to electrophoresis. There are a variety of there are a variety of matrix effects with your actual samples, which can give rise to small bumps or peaks, which might need to be explained. But usually you can do this by reflexing on immunofixation to determine whether or not the sample is okay. You can get false positives from radio contrast dyes, and you'll typically see these within sort of anywhere between the alpha 2 and gamma regions. And you can also get other false positives from some antibiotics. As I've said, if there's any unexplained peaks, we would always do immunofixation as a rule out. And generally speaking, you know, we're not going to have issues of missing patients from this approach. You can get very small or unusual paraproteins, and these may be particularly difficult to detect if they co-migrate with some of the other regions outside of the gamma region. So in particular, some of the small paraproteins which may co-migrate in the beta region, that can be very difficult to pick up. You can have very particular IgM paraproteins, which may either migrate to a different position on your CZE versus your immunofixation gel, or they may not migrate properly at all. And they can actually migrate in several different places as well. So that they can be slightly troublesome. And in some of these cases, especially with your IgM paraproteins, it's actually quite useful to use reducing agents like beta-2 mercaptoethanol or DTT. There are other interferences. So one of the more recent therapies, DARA, it is based around an IgG monoclonal antibody, and it does show up usually as a small IgG kappa paraprotein within the gamma region, typically not more than about 1 or 2 grams per litre. So you just need to be aware that if a patient is on DARA, that this may be the reason you're seeing this paraprotein in there, and it can have implications for if you're considering whether or not a patient has had a complete response for therapy. The key thing here is it's possible that any paraprotein may go undetected by electrophoresis in some cases. So if there is any potential doubt, it's always best to send a repeat sample after you've had those results come back. And you can always phone up and request the immunofixation to be added on. So there is some guidance, again, by Myeloma UK around laboratory investigations, and this will give you a whole host of things which the laboratory must, or is suggested that the laboratory needs to comply with, from pre-analytical to analytical and post-analytical recommendations. So a lot of this is more suggestions than being fixed in stone, and some of it may, depending on how your service is put together and run, may not actually work in this case. So this is based off the University of Oxford Hospital's service, so just bear that in mind if you want to go away and have a look at some of that. And it's also useful to be aware that some results we should be phoning out. And again, this is often based, and again, it will vary a little bit from place to place, and there's some general guidance from the Royal College and based around Myeloma UK guidance. We would tend to phone out any significant new paraproteins. So these would tend to be paraproteins greater than 30 grams per litre, where there could be presented myeloma. We would alert maybe hematology to any of these sorts of large paraproteins as well. They generally already know about them because they've generally been referred. And the other key thing is to also contact clinicians around any significant changes of paraprotein concentrations. So if you've got a stable paraprotein which has been around, say, 10 grams per litre, and it jumps up by an increase of 5 grams per litre or more, typically we may consider whether or not we need to phone those out. We would also phone out any substantially abnormal free light chains. As a must, if we see something which is very high, where you've got the uninvolved light chain is suppressed compared to our involved light chain, you have a ratio of either greater than 100 or less than 0.1, we would always phone these out on the first occasion. And if we had also seen any particular pretty abnormal results just below that, which had been either gone to come from an A&E setting, and maybe the patient has been discharged and gone back to their GP, again, we would notify the GP so that these patients can be followed up as appropriate. There's a little bit of guidance around minimal retesting intervals. It's suggested to be around about no greater than 3 months, but this is just based around from a screening sort of approach. If you're looking at follow-up to particular treatments or remission periods, then again, you may want to do this far more often, maybe sort of every month or so. So when we think about the overall diagnosis and management of myeloma, we can broadly split this into 3 categories. We've got our MGUS patients, so these would tend to have paraproteins less than 30 grams per litre. We've got bone marrow clonal plasma cells of less than 10%. And there's the key thing is there's no organ-related or tissue impairment. When we move on to the asymptomatic myeloma patients, formerly known as smouldering myeloma, we kind of reach sort of an in-between state of this. So you've got either your paraprotein being equal or greater to 30 grams per litre, or having substantially abnormal free light chains, or the bone marrow clonal cells being greater than 10%. Again, the key thing here is no related organ tissue impairment. And finally, we have our symptomatic patients. So this is where they would have a paraprotein present with an abnormal free light chain ratio and potentially bone marrow clonal plasma cells present with myeloma-related organ tissue impairment. So when we're looking at our asymptomatic smoldering myeloma, we can use a criteria around what is the paraprotein type, what's the concentration of that paraprotein, and what are their free light chains. And we can use this all together as a criteria to effectively look at whether or not we consider these patients to be low or have an intermediate risk or indeed a high risk. And where they have a low or intermediate risk, the general sort of approach would be to carry on observing them. Where we have a high risk, so you may have all three of those factors, in particular, if you have a free light chain ratio, which is very abnormal, so greater than 100 or less than 0.01, this may be an indication that you may want to start treatment early. And there is some data around this which suggests that there's a benefit to patient outcome. So when we think about MGUS, the key thing here is an MGUS paraprotein is not a B-cell malignancy. So effectively, you've got no apparent clinical effects, and many of these patients will never go on to develop myeloma. The general guidance around when you need to recheck these patients is roughly about 3 to 6 months. The guidance varies from sort of laboratory to laboratory. If you look up on UK myeloma, they kind of suggest around sort of that 4-month period. Some of these sorts of MGUS paraproteins may well be transient. They can be related to other systemic conditions, and they can be seen quite widely through an aging population. They can be persistent, and they can remain every single time you detect monitor patients. We've seen some patients have MGUSs for well over 10 years, very consistently. In terms of when do we want to actually refer these on to hematology? Only when we've got pretty much more significant concentrations of the paraprotein. So generally for IgGs, which are considered a slightly lower risk paraprotein, it would be when they've got concentrations of equal or greater than 15. And for your IgAs and IgMs, it would be equal or greater than 10. So again, lined up with this, there shouldn't be any other abnormal results. So the BJP, there's no BJP present if you're looking in urine, or if you're looking in your serum free light chains, generally speaking, you'll be looking at anything which would have a ratio greater than 10 or less than 0.1. It's important that we follow these patients up because approximately over the course of the years going on, there's roughly, on average, a 1% risk of progression to a big B-cell malignancy. And we can see that actually that risk is very dependent potentially on the paraprotein concentration level. So the higher your paraprotein concentration level, potentially the higher the long-term risk over a period of years that you have of progression. And indeed, the Mayo Clinic has pretty much lined up some data from this in terms of looking at a low risk, a high intermediate type risk, and a high risk based on all these sorts of risk factors. So the key thing in the future would be to try and find some other biomarker which could possibly tell us which of these MGUS patients may go on to develop and progress to a B-cell condition such as myeloma. And they are looking, this is the iStop study, which is looking at how often and what the benefit is to monitoring all MGUS patients. And effectively, they've got sort of 3 different arms to this study where they're looking at no further workup on spotting or discovering an MGUS, using the IMWG guidance which is pretty much what we currently use to look at follow-up for MGUSs, and then a more intensive monitoring period. And then they are sort of, I'm trying to think how far along they are with this now, but they are, it's something to keep an eye out for in the near future. So although we have our MGUSs, and they tend to be our small paraproteins, there are actually also a group of other conditions which are monoclonal gammopathies of clinical significance rather than unknown significance. Now, these are pretty rare. They tend to be relatively small paraproteins. And one of the ones which at Imperial we kind of come across a little bit more often is the ones of renal significance, and it's pretty much just because we have such a big renal population here. There aren't the same sort of symptoms or criteria of some of the other B-cell conditions. And what we have here with these clones is direct deposition of the immunoglobulin and monoclonal, say, IgG in a lot of these cases into the nephron. And this basically causes your renal failure. They can be particularly difficult to diagnose, and some of them will have completely undetectable paraproteins. So you'd only ever spot them if you did immunofixation. Some of them also have marginally abnormal free light chains, but again, it wouldn't be the sort of thing which you could easily spot. It's a little bit like some of the cases of oligosecretory myeloma in that respect. So in terms of how we can use protein electrophoresis and free light chains for monitoring response to disease, we've got a whole host of response standards which have been set out by the IMWG. So in particular, I'm just going to sort of mention sort of like the complete response and the stringent complete response. So in terms of, these are sort of the more ideal sort of scenarios where we would generate a negative immunofixation of serum or urine, and in terms of a stringent complete response, we also have the normalization of the free light chain ratio. And this is sort of like the response criteria, this is where we'd like to get to. So the deeper you get in these sort of response pathways, the longer the remission is. So that's why we're aiming to get there. And we can use these techniques in the laboratory to help with monitoring. We can also use them for monitoring the progression of disease. So we can see where we have increases in our paraprotein concentration. And this can then trigger us to actually start looking at is their progression here. Again, similarly, we can also look at the free light chain assay in a similar vein. So this was our previous laboratory workflow, and we used to use both BJP and free light chains. And I'm just going to now sort of mention and give a very brief sort of overview of how we went about changing over to free light chains, because this is one of the struggles that some laboratories have had. So why would we even want to go over to serum free light chains? I mean, I've already mentioned that it's obviously in the guidelines, but why is it in the guidelines over Bence-Jones protein? So when we kind of looked at how many of our own sort of a cohort of patients, and this was sort of back in sort of around about sort of 2018, how many of our negative PEP requests had actually had serum free light chains requested on them. And it was a very, very small percentage, even though that this is actually what the guidance was recommending. And it's important to remember that around about 20% of all myelomas are BJP only. So pretty much the data which we had would suggest that free light chain analysis at that time wasn't really being utilized at all. So with both assays, which is the better assay? I mean, both of them, if you look through, there's quite a lot of published data in the literature, and both of them have a fairly similar performance. There's some suggestions that the free light chain assay may be more sensitive, but this is really up for some debate. The key thing at the end of the day is the urine availability. So when we looked at how many samples actually had urine sent with them, it was around about 20%. And in some cases, there have been other studies which have reported even less than that. So generally speaking, most centres would only ever see 20 to 30% of samples coming with urine. And this is a key point because, as I say, we've come from a position where 20% of all myelomas are going to be free light chain only. So we are potentially missing quite a few cases. The free light chain assay itself can be performed on the same serum sample that turns up in the lab for electrophoresis. We can do it on an automated platform. The analyzers which we now have in the lab have progressively got better. I mean, the most recent ones we have are effectively random access analyzers. So we can just load on the samples and get through, hundreds a day if we need to. As a result, the turnaround time can be very quick. And we don't need the same sort of level of staff to run all these assays if we compare it to BJP. So with your BJP, Bence-Jones protein in the urine, you would often have to concentrate samples. So you'd be centrifuging all your samples, concentrate them using various protein-specific filters. You'd then have to run them all on electrophoresis and immunofixation gels. Again, very manual-based tasks. There is potentially still some place for BJP, but as an upfront sort of screening tool from a diagnostic point of view, this is why I think free light chains has come out on top. So we updated sort of our approach to this, and a lot of it was born out of necessity as well as the recommendations from the guidance. So we launched this back in April 2022, and we replaced our free light chain testing with, our BJP testing with free light chains. And this was initially has been for all of our GP patients where they can no longer order a random sample of urine for BJP testing. If they do still want to do BJP testing, we can arrange it, but we always tend to ask for 24-hour urine. So we had a lot of changes over the last few years at North West London Pathology, and part of this was around the expansion of the service. So we now cover not just the Imperial sites, we've also taken on board Chelsea and Westminster, which is now part of Imperial, West Mid University Hospital, the Hillingdon Hospital Trust, and we've also got increased GP provision. And as part of that involved centralising services, reconfiguring the staff and the equipment that we had. And we formed basically a new centralised protein service as part of this. So we went live back in April 21. We had a massive increase in workload since this time. So we've seen around about 70% increase in our electrophoresis workload. So to give you some idea, we went from around doing 30,000 electrophoresis samples per year, and we're now currently doing around 50,000. And we had to manage this within what we already had. So our Bence-Jones protein, we used to do around 30 a week. With the additional workload which we had, we were doing upwards of 90 per week. And it was an unsustainable workload from the urine point of view. And so we had introduced two binding site optilytes, which process the free light chains, and we moved over to these, and we've since obviously gone live just with doing the free light chain requests. So the benefits of the move were obviously that this was all in line with the recommended guidance. We communicated all this with our hematology colleagues, and overall, a little bit of convincing, some presentations and education to our GP colleagues, but it was generally supported. The most tricky thing with anything like this, and this is where other laboratories have found it a little bit more difficult, is being able to have a robust business plan and get the sign-off from your finance department. So a lot of places have struggled because free light chain analysis up front isn't necessarily cheap. It can look on paper as a slightly more expensive version of BJP, but you have to remember that there's a lot more staff time involved doing with processing your Bence-Jones proteins. So we now have two Optilite analyzers used every single day as random access analyzers in the lab. And we utilize these not just now for free light chains, but also beta-2 microglobulin, a host of other lipid proteins, some of our CSF markers, and also haptoglobin. So overall, we've actually moved to basically being a little bit more efficient with some of these less requested tests, because we're now processing them on a daily basis. So other things to consider, again, like with any sort of change in methods, you need to consider what equipment you're using and a full method validation. Ensure you have your staff in sufficient. I mean, we have probably around about at least 2 members of staff running those analyzers, both those analyzers a day. They often work together. Ensure that you've got everything laid out from training requirements. That's not just running your analyzers, but also reporting the work, ensuring that you've got sufficient numbers of staff who actually understand the significance of some of those free light chain results. And also the key thing here is to get your IT department on board with it. I mean, it always comes back to ensuring that you have a very smooth, to have a smooth throughput, to have sufficient and adequate IT. One of the things which we've pushed out is generally good sort of clinical advice for our users. And this included advice around the reference ranges, sort of cutoffs, the sort of action limits which they might be looking for, and also to include that sort of reassurance by advertising sort of ourselves from a laboratory contacts point of view. So in terms of, and I don't know how many people are familiar with free light chains, so I'm just going to really run through sort of a summary of the education advice which we've provided. So just to think about what we're actually measuring first, we've got our free light chain assay. So we're looking at a previously hidden surface on these free light chain molecules when they're secreted. And what we'd usually expect in a normal patient, you'd have a normal kappa and normal lambda concentrations within the reference ranges, which gives rise to a normal ratio. So very straightforward in terms of interpretation. When we have a suspected monoclonal gammopathy or MGUS, we would expect an abnormal ratio, and this could be due to high kappa concentrations with maybe suppressed lambda, or indeed the other way around, so you could have a suppressed kappa and a high lambda. The key questions I often get asked, and it's a very stereotypical thing, which I think people just need a little bit of reassurance around, where you have increased kappa and lambda concentrations, but effectively the ratio is normal. So this is an incredibly common observation. Tends to be related to any systemic inflammation, infection, other autoimmune diseases, and in particular renal impairment. And we do have a separate renal reference range. And even outside of those ranges, you may have mildly increased ratios, which again tend not to be of any significance. So what the key ones to look out for, the key ratios which are very particularly abnormal, would be where, as I said already, where you have ratios greater than 100 or less than 0.01. These are basically myeloma-related events, and they require an urgent referral. Abnormal free light chain ratios, which are present in MGUS, may also indicate a risk of potential risk of progression. And so where we have ratios which again are above 10 or below 0.1, again, we would then generally suggest that they require a follow-up. Again, in cases of smoldering myeloma, the ratios are slightly less than that. So again, it may be higher risk of progression in these cases as well. And just as a note at the bottom, I have just put in just a reminder that the different free light chain assays can't easily be compared to each other, particularly binding site compared to some of the other ones, say like the Siemens assays. They have different types of antibodies. So the Binding site assay uses a polyclonal antibody, whereas the Siemens assay uses a monoclonal. So we've given out this as sort of general guidance. I think you do need to take this as a little bit with a little bit of a pinch of salt. This is general guidance. It probably needs some review, as do a lot of the reference ranges around serum-free light chains. But hopefully, as this becomes a more and more common test, we would see additional publications around this. So there may be other things that influence, sort of generally speaking, the slightly more marginal increases in kappa or lambda light chains, which can be related to things like age and sex as well. And this is just our algorithm from which we've released to our GPs, and it gives them a pretty good sort of overall guidance in terms of which patients need to be referred and what needs to be looked at. It's probably quite a good one if you're going to sit any exams. So if you're going to not remember anything else in this talk, it's just probably to learn something like this. So I will finish there. I think I've run out of time anyway.
Where did you source the LCH reference info in the UK?
So these were recommended, again, they came from binding sites, which I always have a little bit of trepidation with using any of the manufacturers' reference ranges, but they had done quite a lot of studies where they'd looked at both renal patients and they'd separated them out from patients with myeloma and other paraproteinemias. So that's where those reference ranges have come from. As I say, I think all the reference ranges probably need more work, and I think this is something which will probably be gaining some sort of traction. I mean, we've probably got quite a lot of data within Northwest London pathology, which we could look to probably tease some of this out. Actually,
there's another question there about SLC requests from all GPs, or do you vet these?
So we allow them to come from all GPs, and we ideally what is recommended under some of the laboratory guidance from Myeloma UK is to have like a standard upfront package for effectively myeloma paraproteinemia testing, which should include free light chains as part of that.
So if we find 2 or 3 small bands in serum PET gel, should we report them as there can be more than the bands?
So this is there is a little bit how long's a piece of string. So if you find maybe 2 or 3, you can report them individually. I would say as soon as you get to 3, you're kind of looking at more of an oligoclonal type pattern, which would be related to an infection inflammatory type response. But it's important still that you track these. So you'd recommend that there be follow-up with a repeat electrophoresis 3 or 6 months' time, and then you can track those paraproteins using, you know, all of the patterns will be stored in your software, so you can track them over time.
There's a question about reflex testing there. And there's point.
Let's check it. That's 2.
So for the one here, which is about should we do reflex testing for protein electrophoresis and free light chains where you've got high total protein results, particularly in GPs, which I think is one of the areas we looked at. So we did look at this. So we looked at what was providing us with the most information, which was a little bit more sort of sensitive and specific. Was it the total protein result or was it the globulin result? So what we generally saw is that it was probably worthwhile reflexing protein results, which were total protein results where they were around about sort of 85 or 90. And with the globulins, it was around about sort of your 50 grams per litre. And the globulins had a better performance than the total proteins. But indeed, if you've got a total protein of around about 100 grams per litre, then yeah, I would suggest that you reflex your PEP and free light chains.
We tend not to accept Vince Jones proteins in urine. So would you please shed some light on this practice? Do you think it is necessary on what and when? where in what cases we need to do Vince Jones proteins, because my understanding is FLC will cover in urine and in.
Yeah, so I mean, I would completely broadly agree with that. In the vast majority of cases, there has been some suggestion that in some of the amyloidosis patients, it may be worth doing BJP analysis. There is the argument, and some laboratories have taken this approach, is to pretty much to not do any BJPs at all anymore. And I think that's going to probably progress over time. So, I mean, I think our own laboratory, we probably shouldn't be doing as many BJPs as we do. So we may, again, look at reducing the access to that from a inpatient, outpatient point of view. Again, it's comes back to how worthwhile is BJP how worthwhile is it? And if you're looking at the actual guidance which has been provided, the guidance is pretty clear now, which basically says, it shouldn't be used as a routine test. So I think it's for laboratories and their clinicians and to decide what sort of approach to take. There are your sort of isolated cases where you will see BJP, which may be a benefit compared to maybe some interferences and some free light chain assays. But as a standard approach, you're not going to be wanted to do BJP on as an upfront test.
Thank you very much. That's fantastic. Thank you. So next up is Professor Karim Meeran, who is a professor of endocrinology here at Imperial College. He is the endocrinology lead here and is also the deputy director of medical education at Imperial College. And he's going to talk to us today about disorders of steroidogenesis.
Okay, thank you very much. So thank you all. So this is my plan. We're going to just have a quick reminder about steroids, from peptide biohack to steroids. And then we're going to talk a bit about congenital adrenal hyperplasia, which is, of course, the key set of disorders of steroidogenesis. And then I'll talk about how we treat these people briefly. So the biochemistry, first of all, adrenal hormones and steroids, all of, as you remember from your medical school days or university days, come from cholesterol. And these numbers are quite crucial in terms of working out, because all the enzymes are named after these numbers. So this is the carbon numbers, okay, of this 27 molecule cholesterol. And the key thing really is that all of the steroids come from this, and a tiny modification in the structure causes an enormous difference in its function. Okay, and that's really important to recognize. So I'll just quickly remind you about steroid synthesis from the past. So there's cholesterol at the top there from a very old physiology textbook. And you basically hydroxylate it in several positions, and you end up with either aldosterone, cortisol, or the sex steroids. Okay, and this is a pathway that a lot of us have learned by heart. Okay, you start with cholesterol. So the first thing you chop off the side chain and you get pregnenolone. And then this is position 3. You hydroxylate position 3 from this alcohol group to a ketone, and you end up with progesterone. Okay, and that's simply by oxidizing this 3 times effectively. Okay, so that's cholesterol, pregnenolone, and progesterone. And this is the common, let's call it, progenitor for these 2 steroids down here. So the next stage is 21 hydroxylase, and then 11 hydroxylase. And if you go through this pathway, you'll see if you hydroxylate positions 21, 11, and 18, you end up with aldosterone. Okay. However, if you make a slight variant on that, and instead of using 18 hydroxylase, use 17 hydroxylase, it's a different carbon position that's hydroxylated, you end up with cortisol, okay, which has got a totally different function to aldosterone. So cortisol is a glucocorticoid, and the other column was aldosterone mineralocorticoid. So by simply changing a very tiny hydroxylation position, totally different enzyme, you get a completely different function. Now, this becomes clinically very important if these things go wrong. And what we mean by go wrong is one enzyme is either inhibited or is congenitally missing. So this is the same pathway, but looked at from a protein perspective. So all these proteins are the enzymes. They're all P450 hydroxylase enzymes, and this is 17 hydroxylase, side chain cleavage, 21 hydroxylase, 11 hydroxylase, and you can see you can make the same substances. So these proteins catalyze all these changes, and if one of them is missing, you get a complete shift in this pathway, of course. And I'll just show you what happens clinically. So this is the same thing drawn out from a very old textbook that I found from about almost 50 years ago, where they were starting to work out the enzymes. Okay, and if you look at the zones of the adrenal, they've got a slightly wrong way around. So the outer zone of the zone of fasciculata is where you make aldosterone. So the zone of fasciculata contains the enzymes 3, 21, 11, and 18 hydroxylase. And the zone of glomerulosa, the inner bit, it's the wrong way around here, contains almost the same, but there's no 18 hydroxylase. Instead, you've got 17 hydroxylase. Okay, and these enzymes basically control the adrenal gland. So this is what angiotensin II does. So when your blood pressure falls, you need more aldosterone. And so that switches on the path that ends up in angiotensin II. And your adrenal gland in the outer zone fascicular glomerulosa has got receptors for angiotensin II. And the angiotensin II will turn on these enzymes. Okay, that's effectively what happens. On the other hand, ACTH stimulates the zona fasciculata, and it turns on these enzymes, the same ones, except there's 17 instead of 18 hydroxylase. Okay, and this basically controls the production of cortisol. Okay, so they're all hydroxylases. Now, the commonest form of steroid abnormality is 21 hydroxylase deficiency. Okay, if you're missing that enzyme, we're in trouble because you will not make enough aldosterone or cortisol. Cortisol has diurnal rhythms. If you measure it, this is in a whole bunch of healthy people, you'll see that there's a trough level of cortisol at about midnight, and it peaks at about 8:30 in the morning if you have a daylight cycle that you tend to wake up at 8 o'clock. So these were healthy volunteers who participated in a study, and they were kind of slept at 10 p.m. and woke up at 8 a.m. And they had measurements of the cortisol continuously, and this is the kind of circadian rhythm that you see. Now, if you are missing one of these enzymes, supposing you have got, it can be complete or it can be partial. Now, supposing you've got complete deficiency of the enzyme 21 hydroxylase, the key questions are, what will be missing? Without those things, how long will you survive? And which hormones will be in excess? Okay, so clearly, if you have complete deficiency of 21 hydroxylase, you can't live very long at all because you've got no cortisol, and importantly, you've also got no aldosterone. So this is like Addison disease. You've got no mechanism to maintain your blood pressure, you can't retain sodium, and you can't increase your glucose levels controlled by the adrenal gland. So without these two, you will die very, very quickly. Okay, so if you are born with complete deficiency of this enzyme, you will be born without cortisol and aldosterone. Now, before you're born, you've got them from your mother, the placenta, so you're okay. But the minute you're out, you're in trouble. Okay, so you're not going to survive very long at all. You'll have a salt-losing crisis because you haven't got the mechanism to maintain your blood pressure. What about what will be in excess? Let's back at this pathway. So if you are missing these enzymes in utero for the whole 9 months, you will have a high level of ACTH because there's no cortisol. And so the neonatal pituitary will push this to try and detect some cortisol. Not possible. So the outcome will be, this is turned on massively. There's no 20 hydroxylase to be turned on. So you have a large amount of this precursor, 17 hydroxyprogesterone in the adrenal glands, which get bigger and bigger and bigger. And that's why it's called congenital adrenal hyperplasia. So when you're born, you have huge adrenals that can't make cortisol. Okay, it's got that name. But instead, they make a large amount of the androgens because this goes down this pathway. And these, by mass action effectively, you have a slight excess of testosterone, but testosterone is in nanomoles per liter, and cortisol nanomoles is 400. Okay, so testosterone will be about 10. So that goes up by even 10%. You have a big clinical impact. So these children are born with an excess of testosterone, and in utero, that will, if they're a girl, cause clitoromegaly and labial fusion and ambiguity. If you're a boy, it won't have any impact at all. It'll just make you more of a boy, which you won't see any difference at all. Okay, so the boys are missed. The girls are born with ambiguity, and so the minute they're born, the pediatricians go, oh, there's something wrong here. This child might have CAH, and so they keep them in hospital and they make sure they don't have a salt-losing crisis and they give them steroids. But the boys go home and have a crisis at home potentially. So that's a problem. And of course, if they become hypotensive and brought back in, luckily, the standard fluid everyone gives people when they're a bit unwell as a child is normal saline, which is the right treatment, and therefore they survive. But this is complete 21-hydroxylase deficiency, okay? So the excess hormones are sex steroids and testosterone caused by the excess of 17-hydroxyprogesterone. So obviously, the way to detect these things is to measure the precursors, measure the cortisol, and measure the 17-hydroxyprogesterone. Will be very high, and that will give you the answer. So this is by a long way, the commonest form of CAH, okay? They present as a neonate with a salt-losing crisis. And that's because before birth, while they're neutro, they have a lot of excess androgens. Okay, as I've just said this, the girls are ambiguous and the boys are not. Okay, what about partial? Now, partial is interesting because partial means you will not die of a salt-losing crisis. And if it's partial, you might be okay because you have a high ACTH and a high renin driving these two pathways. So that will overcome this block to some extent. But the cost will be in excess of sex because you have a lot of 17-OHP and only some of it will go down these pathways and some excess will spill over to the androgens. And so as a consequence, you present with what we currently call simple virilizing CAH. In other words, you don't have a crisis, you're not hypotensive because you'll compensate by a high renin and high CTH, which will keep you alive, but you will present therefore at any time in life later on when someone thinks of it, okay, because you are partially deficient in 21, and therefore your problem is going to be excess androgens. So although you are deficient in cortisol and aldosterone, that can be overcome by the drivers, and therefore you end up effectively with this problem: a high testosterone, a high 17-HP, and if you're a girl, then again you'll be virilized, but not very much because you haven't got it in utero beforehand. And later in life, you might start to present with what people think looks a bit like PCO, and therefore you're wrongly labeled as PCO with increased hirsutism. And it's quite a late diagnosis until somebody thinks, wait a minute, we need to measure the 17-hydroxyprogesterone. That's a really important marker in someone who is virilized. So when do they present? Well, it can be any time because they don't die young. And so they might go on for a long time until they seek some kind of attention or a test. It's going to be missed, okay? So they can go through the whole of puberty without knowing. Sometimes, because they've got too much testosterone, the boys go through a precocious puberty. Now, that can be a normal precocious puberty because although they drink like the testosterone, that can drive the hypothalamus to switch on early. And so it's missed, even though it happens really early. So the main problem really is too much testosterone in these individuals, essentially. Precocious puberty in boys, and virilization in girls due to adrenal testosterone. Okay, so this is again from that old textbook of how these people present sometimes in later life when no one's looked for it, because the problem is they have not enough cortisol, a very high CTH, very big congenital hyperplasia, and excessive testosterone effectively in partial CAH. Now, of course, this is the pathway I showed you earlier. And what you want to do in order to try and treat these people is to suppress the ACTH, and that will suppress the testosterone coming from the adrenal glands, because what you want is for the testosterone to come from the testes. So just to summarize, you've got adrenals pushing out testosterone. That testosterone will suppress your pituitary LH and FSH. Therefore, your testes will not be driven, and therefore you'll get through this young life with excess testosterone coming from the wrong place. Okay, and that's a problem because it means that these children will be infertile. You need to turn off the adrenal testosterone to allow the gonadotropins to rise to switch on their own normal puberty. Okay. Yeah, so this is the problem. So what we do in someone who presents with mild hirsutism, before you assume it's PCO, which is very common, you need to make sure they haven't got partial congenital adrenal hyperplasia. The treatment of this is very different. You just give them the missing glucocorticoids. And so you measure cortisol and 17-hydroxyprogesterone and dynamic test. The dynamic test is a synactin test where you give X-ray CTH And what happens, of course, normally is the cortisol shoots up to about 400, but in these patients, it doesn't go up to 400, it goes to about 200, and the 7-OHP rises phenomenally. And then you know that the patient has got CAH. It's very important to be careful about progesterone, and therefore in a girl, you want to make sure they're not, haven't got a high progesterone, okay, and therefore choose the time of the cycle in the early follicular phase, otherwise you'll get a false positive. So how do you treat these people? There's two things, okay? Clearly, if they've got a salt within crisis, you need to replace the missing hormones, but you also need to suppress the adrenal androgens, which are really unpleasant for these individuals, okay? So let's think about aldosterone. Aldosterone has a very, very short half-life, and therefore it's not practical. We don't give patients aldosterone. What we do is we modify the molecule by taking a fluorine atom in it. Now, fluorine does not exist in nature. And if you therefore stick a fluorine atom into any steroid, it becomes very non-biodegradable. And therefore it hangs around. There's no enzyme that will break it down rapidly, okay? And therefore, the drug we use is once daily fluorocortisone. We give 50 to 100 micrograms, and that works. And that will completely suppress the renin, okay? And you give enough fluorocortisone to maintain blood pressure. And some people, I mean, we tend to measure the potassium. That's the best marker of adequate replacement. If you give too much, they become hypokalemic. If you give not enough, they're hyperkalemic. So I would go with potassium rather than renin or any other markers, okay? So this is the mechanism. It lasts a long time because fluorine is not a normal substance there. Okay, what about cortisol? Now, cortisol, we would like to give this done on a rhythm, okay? And cortisol has a half-life of about 4 hours, okay? And I showed this earlier, the peak level is about 8:30 in the morning. So what we have done in the past is given hydrocortisone, which is the natural cortisol, but it's got a half-life, so it goes down, zooming down like this. You give it at 7:30, 8 o'clock in the morning, there's a huge peak, and down it goes, and there's none left, okay? So it's too short for one daily administration. So what we do is we give it 3 times daily. And that tends to work okay, but we're starting to find that these little peaks here are not good for you. They tend to overshoot. I mean, we're not good at giving steroid replacement. And so we're doing a lot of work here, in fact, to try and work out how we can smoothen this curve out. And a very simple way is to give a long-acting steroids rather than these triple peaks that we get with thrice daily hydrocortisone. So believe it or not, the molecule that seems to work best is one with a double bond here, which you all know as prednisolone, a very straightforward, well-recognized, once daily administered steroid, okay, glucocorticoid. It's more potent than cortisol. So it's got over twice the affinity for the receptor. So we tend to give, instead of 10, 5, 5, it's 10 milligrams in the morning, 5 at noon, and 5 at 4 p.m. of cortisol, you can just give 3 milligrams of prednisolone once daily, okay? And if you do that, we've set up an assay here to measure prednisolone. You can see that it lasts all day. And we have now got a number of patients on once daily prednisolone, 1 dose in the morning, and it seems to work for once daily administration. This is in fact from here. When we started out doing this, showing that prednisolone once daily seems to be the answer. Very, very low doses compared to what we have used traditionally. We seem to be much better. This is now about 8 years old. Okay, so that's prednisolone. Another very potent steroid is dexamethasone, which is again another fluorinated steroid. And if you stick fluorine to prednisolone with double bonds, you get dexamethasone. Now, dexamethasone is very potent, has a very long half-life of 30 to 54 hours. So it makes people Cushingoid. It's an excess, it's too much, and anybody who takes dexamethasone will end up with Cushing syndrome, the features of excess cortisol. We've all now used Dex in large doses for patients with COVID. It seems to be very effective at suppressing the inflammation. So for inflammation, it's very good, saves lives. But for replacement, it lasts too long and it suppresses androgens a lot, which is a good thing if you've got congenital adrenal hyperplasia. I'll just quickly cover one other drug that's being developed. That's just hydrocortisone. But it's a cleverly designed delayed release preparation where you take the drug last thing at night and it sits in your gut and doesn't release. And then the plan was at 5 in the morning, before you wake up, it goes and it releases, and you then get a nice rise early morning in cortisol. Now, unfortunately, it's a bit early. The rise starts at about 2 a.m. and its moment peaks too early. And so they're trying to modify it again to make it a bit more effective. But the drug you'll see used is called Chronocor F-Modi, now licensed for congenital adrenal hyperplasia. And the idea is that you really want to suppress the androgens. Okay, so the whole point of treating these people is to suppress the androgens and get the circadian rhythm right. And no, the short-acting drugs, prednisolone and cortisol, can't do that because you wake up and then take the drug, and it's not practical to wake up, have a drug, and go back to sleep. So this is what they've done with their Chronocort, which you take it twice daily, and it seems to mimic the early morning rise before you wake up better than anything else. In fact, outcomes waiting to see, but this is their data, which is quite interesting. So I'll just show you what this is. This is patients who have got CAH, okay? And if you look at the black lines, these are patients on conventional standard hydrocortisone. And you can see they've got quite a high level of ACTH all the time. And that causes them to have a very high level of the androgen precursor, 17-hydroxyprogesterone. So early morning, it rises, okay? Now, if you give the patient Chronocort, what you're effectively doing is at the night before, what you will do is you will suppress the ACTH, okay? And what that does overnight is it keeps the ACTH low and therefore prevents this rise in 17-OHP. And the aim, I don't know if it's going to work, but the aim is to prevent early morning realization. Because if it works, it's just coming out now, available. If it works, it will have a big impact in CAH. At the moment, the standard treatment for CAH is to suppress the androgens with any of the steroids you can, as many times a day as you possibly need. And you measure these 17-OHP, and if you can get a lower level, that's good. This seems to do it without too much excess dose. So taking it the night before might be the answer. That's the future. So what you've got to do is suppress the adrenal androgens, because the adrenal testosterone otherwise will suppress your LH and FSH, which will result in your testes not making testosterone, and therefore your sperm production will fall. So if you want fertility, you need to up the dose of glucocorticoid until you've suppressed the testosterone. So options are to give either hydrocortisone lots of times a day, prednisolone probably more than once daily. I mean, once daily is perfect if you've got no adrenal, just replacement. But if you want to suppress the androgens, you need to give it more often, or use once or even twice daily dexamethasone. Now that will make you Cushingoid, but it will suppress the androgens. So that's a cost benefit that you need to think about. Okay, so that's those enzymes. Now, that's 21, which is the commonest, okay? Of course, you can miss any of the other ones as well, and there are rarer causes I'll talk about in a minute. I'll just show you this one very good study that's come from, in fact, Brazil, 20 years ago. It's a really good study, and it's very well hidden, okay, in a journal that nobody reads, but actually it's probably one of the best bits of data, and I'll use this to actually drive what we're doing here. What they point out is that multiple daily doses of hydrocortisone do not reproduce cortisol chronobiology. In other words, they're saying it's not what happens normally. And they were the first people to suggest that prednisolone once daily, a single morning oral of prednisolone, might be better. This is in CAH, right? And effectively, what they did was they blind and randomized these patients to either prednisolone or hydrocortisone 3 times a day, and they had placebos in the other arm. And the outcome, to summarize this abstract, is a single morning of prednisolone achieved better clinical and hormonal control than thrice daily hydrocortisone. Okay, so that's a really good study. And they pointed out that the potency of prednisolone was like almost 7 times higher, 6 to 8 times higher than hydrocortisone, which is something that we didn't know. So prednisolone is a really potent steroid, but it's very effective according to this study in congenital adrenal hyperplasia. Because of this study, we now realize that a full replacement dose of prednisolone, 3 milligrams, is the same as 20 of hydrocortisone. And we've used this and found exactly the same outcome. So the textbooks that you all read that say 5 of prednisolone are wrong, okay? The correct strength is 3 milligrams. It's 7 times more potent, not 4 times more potent. Now, this data has come from the anti-inflammatory group, which is a different group, okay? For inflammation, maybe that's right. Maybe 5 milligrams is the same as 20. But when it comes to replacement dose, prednisolone is 7 times more potent than hydrocortisone. I'll just tell you quickly about a patient to illustrate some of the problems that these patients have. Right, she's a young lady who had a salt was in crisis shortly after birth, and she was therefore put on replacement. And in her childhood, she's done everything. She's had hydrocortisone, she's on dexamethasone, she's tried prednisolone. When on dexamethasone as a child, she put on a lot of weight, made a very Cushingoid, but it did turn off the androgens and it prevent the hair growth. So her parents kept her on that. But when she got older, she switched to hydrocortisone, which she took a lot of times a day, or prednisolone, which she took twice a day. And that was better than the Dex for her weight. She'd lose weight, but as she lost weight, the ATH climbed and she then went up in androgen production, and this caused hirsutism. Okay, and this in turn would suppress LH and FSH, and she would stop having periods. So what she came to clinic, she came to see us in 2001, and she said that her period stopped, and she tried various doses of prednisolone in the morning and at night. Okay, and what she said was, I hate these adrenals. They're just with testosterone, they're completely useless. I want them out, is what she said. So she had a point, right? And so we thought, well, if we give her, because her point was as follows: if I take a lot of steroid, I become obese. If it's not enough, I become hirsutic. I'm either hairy or fat. Okay, I don't like either of those things. But if you remove my adrenal glands, then I can be like anybody else who's on replacement and just go on PRED3 effectively, because she was on 7.5 to try and suppress the androgens. So in 2002, she had her adrenals removed. Now I was a bit worried because I thought maybe there's something useful. So we did a synaptin test, a long synaptin test we used to do in those days. And her cortisol was 0 throughout. So her adrenals were unable to make any cortisol. And the same with aldosterone. So they were actually not very useful at all. So she did have both adrenals removed in 2002. And she then went on to, like a typical Addison's patients, onto prednisolone and fluticasone. And she's on PRED3, and she's been on that now for 22 years. And she's very well and very happy, lost a lot of weight, and there's no hirsutism, and is very happy. So it's an interesting point. It's not a commonly done thing, adrenectomy, but it was her idea. And she convinced the surgeon to do it, and it had a good impact in there because it meant that the adrenal glands are not making testosterone, not making androgens, and they can be quite troublesome. And she's now got a nice, normal diurnal rhythm. I will just quickly tell you about the second most common CAH, and that's 11-hydroxylase deficiency. So if you're missing 11 hydroxylase, things are a bit different because this molecule here, 11-deoxycorticosterone, is active. And it's very much like aldosterone. It binds to the aldo receptor and causes hypertension and hypokalemia. And therefore, these people cannot have a salt-losing crisis. Okay, that's a really important exam fact. 20-hydroxylase does cause salt-losing crises. 11-hydroxylase deficiency does not cause a salt-losing crisis. In fact, you have the opposite: hypertension and hypokalemia, the opposite of an Addisonian salt-losing crisis. Okay, and that's because they're missing this enzyme 11-hydroxylase. So what happens to them? So if you have a high level of this stuff, this makes you hypertensive and hypokalemic, and also virilized because you have an excess going down this pathway. So when you see someone who's got hypertension as a child, it's unusual, and hypokalemia as a child, what are the causes of hypertension in children? One of the commonest is this form of CAH. And then you look and examine and you find they've got some virilization, and that gives you the clue. So this is an important fact, okay? 11-deoxycorticosterone behaves like aldosterone, and therefore it causes hypertension and hypokalemia. So the excess hormones are different. The excess hormones are 11-deoxycorticosterone and the sex steroids, and the problems they have are hypertension, hypokalemia, but virilization and increasing androgen production. So never have a salt-losing crisis in this condition. Okay. So that's my quick summary, okay? We talk about cholesterol, we talk about CAH. This is the commonest form of 21, and the second commonest is 11-hydroxylase deficiency. And to treat these people, you need to replace the glucocorticoid, but you also need to suppress the androgens. I think maybe I'll stop there. It's 1:15. Thank you very much. Any questions?
It's a good talk. I just wanted to ask a bit more about the prednisolone. So I sort of come across it being contraindicated in children with CAH because of negative impacts on growth. I just wondered, when you're using it, are you using it in children or is it only in adults?
We are. So that study showed the opposite of what you just said, right? So that was done in Brazil, and they showed that the key thing is the dose. Right, so it's not like one drug is better or worse. It's the timing. The timing makes a big difference if it lasted at night. So what you're talking about, we used to use reverse circadian prednisolone, okay? And the aim was to suppress the androgens. And if you do that, it's more potent, so good for the androgens, but it does indeed affect growth. So it's not prednisolone's bad, it's the time that you give it. So if you give it in the morning, which is what we didn't used to do, then that doesn't happen. And if you get the dose right, okay, so you want to give as little as possible, so 3 or 4 milligrams. So, I mean, if you look at the pediatricians, they use whatever they can to suppress the androgens. And if you're a fast metabolizer, then Pred or Dex is better. And if you're slow metabolizer, the high cortisol is better. So what we're finding is that everyone's a bit different. So I mean, there are some patients of ours who are on prednisolone and then hydrocortisone. So Pred in the morning first thing, and then hydrocortisone later in the day, or vice versa. And so this is, the aim is twofold. One is to replace, the other is to suppress. Okay, but prednisolone is fine to use in children. We use it a lot. The dose is difficult. We need to get very low strength ones, which are coming out soon too. Could I comment on urine steroids when working out these patients? Yes. So in terms of the urine steroids, so the good thing about doing a profile is you can see all of those precursors, the 7-OHP, the 11-deoxycorticosterone, and so on. You can work out where the block is from the pattern that you see. So that we would do that. I mean, clinically, the comment is going to be 20-hydroxylase. So typically, we would do a 17-hydroxyprogesterone first. If it's not clear, if it's not an obvious diagnosis, then it's one of the rarer ones, maybe 11 deficiency or 17 deficiency, then the steroid profile is really helpful.
So Dr. Jaimini Cegla is one of the metabolic medicine and chemical pathology consultants here at Imperial, and she runs the Hammersmith Hospital Lipid Clinic, and she's kindly agreed to give a talk today on lipids and lipoproteins, what and how to measure. Okay.
Okay, so hi everyone. That's the Hammersmith Hospital. You can see there where we have our lipid clinic. So a little bit of history to start with. So anyone heard of Nikolai Anishkov? Have you come across that name before? We sort of, in the lipid world, think of him as the founder of atherosclerosis. So he was a physician in the Russian army, but he was also a pathologist, and he got very interested in cholesterol, and he fed rabbits 61 yolks, egg yolks, over 30 days, and then took out their aortas and stained them with Sudan stain, and was able to find that cholesterol. And you can see that beautifully here in this aorta from this rabbit. And then he looked under the microscope at the plaque, and you can see these cholesterol crystals, and he described foam cells, so those macrophages that eat up the cholesterol, and really sort of described this in this seminal work in 1933. So almost 100 years ago, this was first described. And he came up with this really famous dictum, which was, there is no atherosclerosis without cholesterol. And this was quite controversial for many, many years. And there were a lot of cardiologists, particularly here at Hammersmith, and this is a great debate about fats versus cholesterol in the causation of atherosclerosis. But I think we now know, and it's pretty much not really controversial anymore, that cholesterol is certainly one of the main driving risk factors for atherosclerosis. So thinking about cholesterol in a little bit more detail, I think you all know that very, very little of our cholesterol is sort of goes around freely in the blood, and it's mostly carried in these things that we call lipoproteins. And I always think of these as sort of the trucks that take the cholesterol around the body. And it's not just cholesterol; it's also triglycerides and cholesterol esters. And the way that these look, so they've got this hydrophobic core with the triglycerides and the esters in there. And they've got this monolayer of the phospholipids and the free cholesterol. And they all have these things called apolipoproteins, these structures that sort of provide scaffolding, but also have a functional element in how these lipoproteins work. And when we think about lipoproteins, there are some main ones that we really, really need to consider. And going from sort of the left, we've got HDL, and we often think of HDL as the good cholesterol. We'll go into a little bit more detail about that. But as these lipoproteins get bigger, you can see the yellow, that's the cholesterol content, seems to reduce, and the triglyceride content increases. And we've got LDL, which is the main driver of atherosclerosis. And we've got LP(a), IDL, VLDL, and then these chylomicron remnants. And these ones are really big, really fluffy. And I've also got this big sort of red square around these ones that contain ApoB. So HDL contains ApoA1, and the rest of these lipoproteins contain ApoB. And it's these that, in their own right, all of these ApoB-containing lipoproteins are atherogenic. And so you'll see in the labs, one of our things that we have as part of our lipid profile is the non-HDL cholesterol. And that's a really, really simple calculation. That's basically the total cholesterol of all of these lipoproteins minus that HDL cholesterol. And we can separate these lipoproteins by electrophoresis. And again, you can see that you've got these really, really small, dense lipoproteins, the HDL, you've got the various subfractions. And then as we get sort of less dense and bigger, you've got these chylomicrons, and then you've got these really big, fluffy chylomicrons. And remember, these are very triglyceride rich. These are ones that come from diet. They can contain dietary cholesterol and dietary triglycerides. And these are the ones that get stuck in the pancreatic ducts and cause acute pancreatitis. So let's consider these in a little bit more detail. So very, very sort of simply, we can split our lipoproteins into those ones that contain ApoB and those ones that contain ApoA. And so, as we mentioned, the ApoB-containing lipoproteins, the chylomicrons, VLDL, IDL, LDL, and LP(a). And very simply speaking, these carry lipids to the peripheral tissues. And then the ApoA-containing lipoproteins is the various subtypes of HDL. And these do the reverse cholesterol transport. So take cholesterol from the tissues, and that can be from the arterial wall as well. The cholesterol in there is esterified, and then they exchange those cholesterol esters for triglycerides with these other lipoproteins. So now thinking a little bit more about the basic sort of serum lipid measurements that we make when we do our lipid profiles. And these are the three main things that we measure. So firstly, we measure the total cholesterol, okay, and that contains both those atherogenic lipoproteins, but also the HDL cholesterol. So it gives us that total picture, but it doesn't give us the breakdown. And then we've got a HDL cholesterol, okay, and I've written here, this is the anti-atherogenic fraction, and it's important in risk assessment, and we'll go into a little bit more detail. This is actually quite a controversial thing to say, that it's anti-atherogenic, because certainly if you look at epidemiological studies, you can see that there's an association with higher HDL cholesterol and reduced atherosclerotic risk, but this plateaus. So when your HDL cholesterol goes above sort of 2.5, you are less protected by your HDL cholesterol. And actually then we need to think about more sort of function of these, of the HDL lipoproteins, because actually measuring the cholesterol content only gives us some information, but the functional aspects is something that's much harder to measure, and it's something that actually probably has an impact more on cardiovascular risk. So when our HDL cholesterol goes really high, the HDL actually becomes less protective, and it becomes more of an issue. But we measure the HDL cholesterol because in terms of when we want to look at non-HDL cholesterol, we need the total and we need the HDL to get that non-HDL measurement. And we know, I mean, in terms of causation as well, so the epidemiology suggests that there is this association, but in sort of Mendelian randomization studies where you look at people with loss of function variants of HDL, they don't seem to be necessarily protected against cardiovascular disease. So there's still a bit of a question about whether HDL is protective so this whole thing about it being good cholesterol is still up for debate a little bit. And more recently, there have been lots of studies of drugs, the CETP inhibitors, to try and increase your HDL cholesterol, and those have not been so successful. So the jury really is still out there. But nevertheless, as I mentioned, we do need to measure this as part of our, to get the non-HDL cholesterol measurement. And then triglycerides, again, these aren't considered directly atherogenic, but they're seen as sort of a risk modifier. And certainly, if you've got high triglycerides, that is part of the metabolic syndrome. That's because you overproduce VLDL in those circumstances. And certainly, it's a sentinel marker for some of the secondary hyperlipidemias. It's a risk factor for pancreatitis. And we also need the triglyceride measurement if we're going to use Friedewald or some of these calculations for the LDL cholesterol. So these are the three sort of basic lipid measurements that we actually measure directly in the lab. Let's now move on to sort of calculated lipid variables. And the two ones that really come to mind and, are part of our full lipid profile are the LDL cholesterol and the non-HDL cholesterol. So as we talked about, sort of LDL cholesterol considered the most important class of atherogenic lipoproteins. And traditionally, this has been calculated in most labs and certainly is still calculated using the Friedewald equation. This is a really straightforward equation. It's been around for about 50 years. And basically, it's your total cholesterol minus your HDL cholesterol, and then you estimate the VLDL cholesterol by taking your triglycerides and dividing this by 2.2. And then we've got non-HDL cholesterol. What's lovely about this is this tells you about the total atherogenic lipoprotein. So it's not just about the LDL, it's telling you about the IDL, the VLDL, the Lp(a) as well. And this can be used as an alternative to LDL cholesterol when your triglycerides are very high, because you can't use Friedewald when the triglycerides are above 4.5. It's not been validated in those very hypertriglyceridemic patients. You don't need to fast for the non-HDL, and it's simpler to calculate. So as I said, it's literally a total minus your HDL cholesterol. And so these two really come to the forefront when we think about estimating risk, cardiovascular risk in our patients. And particularly in the clinical trials, if you look at the RCTs, LDL cholesterol is the main marker, the main primary endpoint for a lot of these trials. Whereas in terms of epidemiology, it's non-HDL cholesterol that's been shown to be the sort of superior marker, and it's better than LDL cholesterol. It's better than the ratio that we used to use previously. So remember the ratio total cholesterol over HDL cholesterol, that's pretty much dead in the water now. We don't really use that much, and particularly, as I mentioned, when HDL cholesterol is very high and becomes less protective, you can get a very low ratio and be falsely sort of reassured that your risk isn't as high as it really is. And then, of course, LDL cholesterol is important in the diagnosis of familial hypercholesterolemia. So one of the things when NICE came out in 2014 and said, we should all be using non-HDL cholesterol, forget the LDL cholesterol, a lot of labs around the country stopped reporting LDL-C. And the problem was, when you're trying to diagnose FH, one of the criteria from the Simon Broom is, of course, the LDL cholesterol, because it's a disorder of LDL metabolism. So we need to bear that in mind. And more recently, a lot of the newer drugs that we use for lipid lowering, because they're very expensive, NICE tell us what thresholds we can use them at, and those are all based on LDL cutoffs. So basically, we need both of these in our standard lipid profile if we want to really sort of look at the patient fully. Okay, now moving on to some other lipid variables that are a little bit more specialist. So the first is ApoB100. And what's nice about ApoB100 is that it tells us about particle number. And as I showed you in that first picture, all of those atherogenic lipoproteins, they all contain ApoB, and it's a 1-to-1 ratio. So you usually have 1 ApoB per lipoprotein, which is really nice. This isn't something that's being used sort of frequently in this country. It's mostly sort of more in specialized services. It has been shown to be superior to non-HDL cholesterol in terms of epidemiology and as a cardiovascular sort of risk biomarker, but it's, it's expensive, it's an extra test, and hence it's not really been taken on fully in as sort of part of the standard lipid profile. If you look at the European Society of Cardiology guidelines, they recommend its use. But of course, that's a scientific guideline. That's not about cost effectiveness. So, ideally, in a perfect world where money wasn't an issue, we would all be measuring ApoB. In some of these disorders of more rare disorders, so hypo and A-beta lipoproteinemia, we get very, very low levels of ApoB, and so that's important in their diagnosis. And then also quite rarely, but not we do see this when in patients with things like primary biliary cirrhosis, LCAT deficiency, and some of these other conditions where lipoprotein X accumulates. That's a very, very hard thing to measure directly. And so we use the total cholesterol ApoB ratio to help us estimate the lipoprotein X levels. And that's because LPX doesn't contain ApoB. So it's a useful way of sort of differentiating it from some of these other lipoproteins. Okay, and then there's ApoA1. So this sort of tells us about HDL particle number, but it's not that same sort of ratio, 1-to-1 ratio that we have for ApoB. So you can have anything from 1 to 7 ApoA1s to HDL in your HDL particle. ApoA1's low in metabolic syndrome. It's very low in LCAT deficiency and fish-eye disease and Tangier, so some of these rarer disorders. But in terms of cardiovascular risk management, alone, it's not particularly useful. As a ratio of ApoB to ApoA1, it can be pretty useful, and again, it does quite well, but it's not really as well standardized as some of these other parameters, and it's not really been taken on as sort of something that we routinely use. And then lastly, Lp(a). So Lp(a) we can talk about, a lot because there's, huge issues in terms of its measurement. It's been very well established now as a cardiovascular risk biomarker. And there's lots of trials going on looking at it as a therapeutic target. So we know that it predicts risk, but we don't yet know that if we lower it, we can reduce that cardiovascular risk. So it's useful in risk estimation. And again, at the moment, it's really only in sort of specialist labs. I think there's about 23 labs in the country that measure it. It's pretty cheap. It's about £12, but it's still something that's more done as specialized through specialized services. Okay, so those are the main sort of lipid parameters that we look at in the lab. What I want to show you here is that actually, the total cholesterol doesn't give you the full picture. So these are 3 different patients, 1, 2, and 3. They've all got the same amount of total cholesterol, the same amount of HDL cholesterol, but the rest of their cholesterol is made up very differently. So this first patient has a lot of LDL cholesterol. This second one has a lot of Lp(a). So that's sort of genetically predetermined. And that third one has a lot of remnant cholesterol, so probably has high triglycerides as well. And so the way we manage each of these patients is quite different. So that's why it's so important to look at that whole profile rather than just the total cholesterol. Okay, and this is what I was sort of alluding to in terms of non-HDL cholesterol and cardiovascular risk. This is data from EPIC Norfolk, and each of these different colours represents one of the quintiles of non-HDL cholesterol. You've got women here and men here, and you can see the higher the quintile of non-HDL cholesterol, the higher that cardiovascular risk. And this is, when these studies came out, and studies preceding this, NICE decided actually non-HDL cholesterol was the way forward in terms of looking at cardiovascular risk in our patients. And so thinking about risk assessment and targets, NICE, certainly in primary prevention, talk about reduction of non-HDL cholesterol. So in patients who have a more than 10% risk of having a cardiovascular event over 10 years, we offer them a statin to lower their cholesterol. And they talk about this, trying to get the non-HDL reduced by more than 40% from baseline. And this is really problematic because for GPs particularly, often you don't have that baseline measurement, and patients really want to know a number that they should be aiming for. So that 40% becomes a really, really difficult thing, doing the maths for sort of jobbing clinicians and trying to work that out. So it hasn't really been very well taken up in primary care, but that's what the guidelines say. And in secondary prevention, this is very, very new, but NICE have just come out with an absolute target for non-HDL cholesterol and LDL cholesterol. And this is literally in the last couple of months that this has been published. And this was after a lot of feedback from people saying that, you know, again, there was that 40% reduction for secondary prevention, and it was something that people found very difficult. So finally, they've gone with absolute targets. Although one could argue that these are very, very high still. And, you know, an LDL cholesterol of less than 2 is probably not adequate for most of our patients. And of course, NICE very much, you know, driven by clinical effectiveness, but also cost effectiveness. And I think the modeling for this is what has really driven this, unfortunately. So, you know, you've got both a non-HDL cholesterol and LDL cholesterol here in these NICE guidelines. As I said, the NICE eligibility for some of these newer drugs is based predominantly on the LDL cholesterol. And of course, for the diagnosis of FH, you need the LDL cholesterol as well. And this is why I don't think that LDL of less than 2 is good enough, because actually we know that the lower we can get the cholesterol, the better. And this is for secondary prevention, primary prevention, both. And you can see that there's this linear relationship between the LDL cholesterol and cardiovascular risk. And we now know, because we're using newer agents that, you know, where we can get the LDLs to sort of less than 1, we can, you know, and that risk reduction continues at those very, very low levels of LDL cholesterol. And so if you look at the European Society of Cardiology guidelines, as I said, they don't take cost effectiveness into this. This is purely a scientific statement. They talk about much more stringent targets. So they talk about, in very high risk patients, getting your LDL cholesterol to greater than 50% reduction from baseline, as well as an LDL-C goal of less than 1.4 millimoles per litre. And very high risk, you think, gosh, what does very high risk mean? But actually, that's anyone who's had an event, as well as patients with diabetes, with complications, and patients with severe CKD as well. Okay, so just to summarize that first part of the talk, in terms of our lipid profile, we should include both the LDL cholesterol as well as the non-HDL cholesterol. The total cholesterol does not give us the full picture. So let's talk a little bit about fasting, because this has been something that, you know, has been discussed quite a lot in the past. And both, you know, we've said that both LDL and non-HDL can be used as treatment targets. But the issue with LDL cholesterol and the way it's calculated in most labs is that we use the Friedewald equation. And that assumes this cholesterol triglyceride ratio is constant and in VLDL. And so you need to be fasted so that you've got, you know, absence of all those chylomicrons and chylomicron remnants. And so this is the Friedewald equation again, established in 1972, assuming that molar ratio of 2.2 in all patients, assuming that no chylomicrons are present, and it's not valid in non-fasting samples. So that initial validation that was done for Friedewald was done in fasting patients. And it comes unstuck when the triglycerides are greater than 4.5. So what are our other alternatives? How else could we estimate LDL cholesterol? Well, we can measure it directly, okay? And this is not used much in sort of routine practice. The reference method is beta quantification. And I think there's literally a handful of labs in the country that offer this. And what this is ultracentrifugation. So you separate the lipoproteins and then you precipitate out the LDL. And it's called beta quant because actually ideally you just want the LDL, but there is a little bit of Lp(a) cholesterol in there as well. But that's the reference method. So it's really laborious. Most labs who do offer this do 1 or 2 runs a week. And so it's not something certainly that could be used as a routine thing in labs across the country. What about homogeneous assays? So homogeneous assays, so like for HDL, you know, we've got homogeneous assays where we can measure HDL cholesterol. There are 5 commercial assays to directly measure LDL cholesterol. And you'd think, great, okay, the patient won't need to be fasted, I don't need to worry about their triglycerides, can do this. Obviously, there's a cost implication because you need the reagents for this. And actually, these don't do so well when you compare them to Friedewald, and then compare them to the gold standard, to the beta quant. They're generally not much better. So most labs don't tend to offer this because obviously there's the cost implication as well. So what about different calculations to estimate the LDL cholesterol? We talked about Friedewald. This is the most commonly applied one worldwide, but there are others. And there's an Indian equation, there's a Chinese one, there's a Spanish one, there's the Martin-Hopkins equation, which you may have heard of. And that was, in 2013, that was touted as the next big thing. This was the thing that was really going to replace Friedewald. But actually, in practice, it's a really complicated thing to institute in laboratory systems, and it's you've got different ratios depending on what the triglycerides are, and it's sort of 180 cell sort of matrix that you need in Excel sheet. It's quite difficult to put in, and initially it was also associated with royalties that the labs would have to pay to use it, so it's proprietary as well. And more recently, we've got the Sampson equation. So this was just published in 2020. So I'll tell you about that. So this is it. This looks complicated, but it's actually not so complicated. And it's not that much more complicated than EGFR. So it's pretty simple to institute in laboratory systems. It's published in 2020, and it was derived from patients who underwent beta quantification, so the reference method versus the Sampson equation, and then validated in a further 18,000 patients. And this was done by the NIH. So Maureen Sampson is the main author, but Alan Ramelay at the NIH was really the sort of senior driving force behind this. And this is the data. So we'll just take you through this. Here on the left, you've got the Sampson, and on the right, we've got Friedewald. On the x-axis, you've got the beta quant. Okay, so you've got the gold standard here on the x, and on the y, you've got the Sampson or the Friedewald calculated LDL cholesterol. And you can see that at those very low levels of LDL cholesterol, the Friedewald sort of falls apart. And in these different colors, you can see different levels of triglyceride. And so at those very high levels of triglyceride, again, you can see the Friedewald falls apart, which is what we would expect. And so Sampson is valid up to a triglyceride level of 9. It's also been validated in non-fasting individuals as well. So certainly here, we've now instituted it and we're using it in non-fasting individuals as well. So that's a real, that's been brilliant, because for GPs, there's none of that faff of having to get their patients to fast prior to the measurement. It's got improved performance versus Friedewald. And really, I think we should be thinking about changing our practice on this. And why this is important, as I mentioned, all of the clinical trials have shown that, are based on LDL cholesterol endpoints. And so measuring it accurately is really, really important. And we know the lower we can get the LDL cholesterol, the more likely we are to get atheroma regression and reduction in cardiovascular events in our patients. Okay, so just moving on now on how we classify dyslipidemias. And the way we think of this is primary dyslipidemias, those are the ones that are present at birth, genetically determined. But to make the diagnosis of a primary dyslipidemia, you first need to rule out any secondary causes. And so secondary dyslipidemias are obviously much more common and as a result of an acquired condition. And traditionally, we always did this using this Fredrickson classification just from the 1960s, and WHO took this up. And this was very phenotypic, so we didn't have the genetics available then, and it was based on electrophoresis. So Fredrickson and his colleagues basically ran the gels, lots of patients with different phenotypes, and saw different patterns on the electrophoresis gels. And I'll just run through this very quickly, but the type 1 is what was initially called lipoprotein lipase deficiency. Nowadays, we call it familial chylomicronemia syndrome, because we know it's not just lipoprotein lipase mutations in LPL that cause this, but it's very ApoC2, but a lot of the anchor proteins that are involved in LPL activation that can also have variants. And the more we're now doing a lot of genetic testing for this, and we're picking this condition up more and more in these patients. Type 2A is FH, familial hypercholesterolemia, and the lipid abnormality here is a high LDL. There's 4 main mutations that we look for, and nowadays, across the country, this is something that's available to everyone, and there's 7 main genetic labs that patients can have their samples sent to. I've put here that the estimated prevalence of heterozygous FH is 1 in 500, but we actually think it's more like 1 in 250 now of the general population. Now, 2B, familial combined hyperlipidemia. This is something, that appeared to be sort of autosomal dominant when you look at families, but actually people have been searching low and high for genes of this, and it appears to be more polygenic in nature. It's very common, but the main things you see are high triglyceride and high cholesterol in these patients. So it's very difficult to know whether this really is an entity in its own right, but it seems to be polygenic. Type 3 has lots of names. So, type 3 hyperlipidemia, it's also called broad beta. It's also called remnant dysbeta lipoproteinemia. So lots of different names for this condition, but predominantly this is a defect where you've got an apode E2 phenotype. Although not all patients who have the E2 actually go on to have the condition. So there appears to you require a sort of second hit to actually develop it. And this is where you have a lot of excess IDL floating around, and that translates into high cholesterol as well as high triglycerides. And then type 4 and type 5 are associated with hypertriglyceridemia. They're not as severe as type 1, which is more associated with chylomicrons. Type 1 certainly seems to present much earlier on with acute pancreatitis, as well as stigmata earlier on in childhood. So I think, just to say that the genetics has really helped us with this, and we're now much more leaning towards genetics in making these diagnoses for primary dyslipidemias. And the way that we think of this in a sort of more modern lipid clinic is we think of, pure hypercholesterolemias, and here we're thinking about familial hypercholesteremia, so monogenic hypercholesterolemia versus polygenic hypercholesterolemia. We have SNP scores we can use to help us elucidate polygenic hypercholesterolemia. And in terms of pure hypertriglyceridemia, we're thinking of FCS, familial chylomicronemia syndrome, or this multifactorial chylomicronemia syndrome, which probably is more polygenic in nature. Then in terms of the mixed hyperlipidemias, we think of familial combined, as well as familial dysbeta, or that type 3 that we discussed with the ApoE2 phenotype. And then finally, disorders of HDL, the main ones we're considering here are atangiosin and LCAT deficiency, and its sort of sister, the fish eye disease. And much more common are the secondary dyslipidemias, and the ones that we come across time and time again. The mixed dyslipidemia associated with insulin resistance and obesity and diabetes, hypothyroidism there, nephrotic syndrome, CKD, cholestasis. And so all of the patients in the lipid clinic, you take a full medical history, but we'll always dip their urine. We'll always look at their renal and liver function, as well as their HbA1c and thyroid function as well. And then particularly in patients with hypertriglyceridemia, one of the most important questions to ask them is how much they drink. And so this is these are the lipid abnormalities you see with each of these conditions. And some of them can be really quite severe. So with nephrotic syndrome, you often see cholesterol levels of up to 20. I've seen. With cholestasis, this is more of an issue with, you can see higher LDL, but you can also get LPX, which we discussed earlier, which can really, really push up that total cholesterol. And then drugs that can cause secondary dyslipidemias. Now, thiazides and beta blockers, you know, they have a they do have an impact on lipids, but it's quite minimal. And of course, you know, it's sort of risk versus benefit in each of these patients that you take into account. But certainly steroids, immunosuppressants, and some of the newer tyrosine kinase inhibitors that patients are taking as part of cancer treatments are very dyslipidemic. Some of the antiretroviral drugs and the pill, the oral combined contraceptive as well. So all these patients ideally should have baseline lipids measured before they commence these drugs. I'm going to end there and take any questions. Thank you. So someone asking, if we are using measured LDL and HDL, is it necessary to do a fasting sample? So it's a very good question. So HDL cholesterol, no. The LDL depends on how you are calculating it. So if you're using Friedewald, then yes, you need a fasting sample ideally. But if you're using one of these novel equations like Samson, or if you're measuring it directly, then you don't need a fasting sample. And someone's asking when to start treating a patient taking retinoids from derm. So I think this question is associated with Roaccutane, which a lot of patients take for acne treatment. And our dermatologists here are really good at doing baseline lipids, but we do see not infrequently patients who seem to have a genetic predisposition to hypertriglyceridemia. You can get really sky-high triglycerides. And in terms of treatment, we're not so worried about cardiovascular risk because, you know, usually it's short-term treatment. It's more sort of avoiding acute pancreatitis. So usually our threshold is around 10 millimoles per litre when we would definitely start treatment. We may go lower depending on, you know, what other lifestyle factors are going on as well. So someone's asked, is there any correction needed for very high Lp(a) levels with the NIH Samson? So that's a really good question. When we estimate LDL by any of these equations, it takes into account the Lp(a) cholesterol as well, and there's no way of getting around that. And that's the same with beta quant as well. So you know, there are equations that you can use to try and correct your LDL for your Lp(a) cholesterol. But actually, if you look at the clinical trials and all of those things, they haven't done that on the LDLs that are used are measured in the clinical trials. And so actually, there's no perfect equation to try and estimate the cholesterol content of Lp(a) because it's quite variable. Some people have 20% cholesterol content by mass, some people have 40% by mass. So it really is, there's no perfect equation to do that correction, and it's not validated either. Someone's asking about the cutoff for non-fasting triglycerides. It's a really good question. Again, we don't quote a non-fasting one. We quote 1.7 for fasting. I think 2.3 is out in the literature for non-fasting. But it's something ideally you want to have for your local population. Will Q-risk scoring move away from the ratio of total cholesterol to HDL cholesterol? I hope so. I was talking to some GPs yesterday, and actually they don't input the ratio into EMIS or System 1. They literally put the total cholesterol and the HDL cholesterol, and then Q-risk calculates it all for them. So I think in the future, hopefully it will go. And certainly, if you look at the European scoring systems, they use non-HDL cholesterol rather than the ratio as part of that. Oh, Becky's asking, what abnormalities do you see in patients on the ketogenic diet? Yes. So I don't have much experience of seeing the ketogenic diet to control seizures, but I've got lots of experience of patients who've turned up in the lipid clinic because they've been on the ketogenic diet because they think it's good for them. And yeah, it's quite variable, but we've got patients who've had a normal cholesterol, total cholesterol 5 pre-ketogenic diet, and it's gone up to 20 millimoles per litre on the ketogenic diet. So, you know, severely marked dyslipidemia. And I think these are probably patients who've had a bit of a predisposition, genetic predisposition, and probably hyperabsorbers of cholesterol. Should we do one more? Do you think that?
Any of the audience at all? No.
Oh, there's a question from Ed.
Do you think there will be enough evidence that we should just be offering effectively statins?
I think we probably should be offering everyone statins already, but I think I don't think that would be very well accepted by the public. I mean, you know, when we see patients in clinic, I think the Daily Mail and sort of Dr. Google and friends and family get to people before we can. And I think doctors aren't very good at, you know, socializing the you know, how well studied some of these medicines are. And the scientific evidence for them, because patients really worry, and they've got it in their heads that this drug is going to cause me side effects before they, you know, before they even start. And obviously it's then a sort of self-fulfilling prophecy. But yeah, I think we know from Mendelian randomization studies that the lower your LDL cholesterol, if it's, you know, genetically predetermined and from birth you have a lower cholesterol, you end up being protected against cardiovascular disease. So there's really good evidence of starting statins early. We have quite good evidence for familial hypercholesterolemia and pediatric patients, and starting statins, especially if you've got strong family history of cardiovascular disease, has good impact on their protection as adults.
Oh.
Yeah. Yeah, so we do.
In other words, does the normal diet affect the cholesterol level?
That's a really, again, an important question. So about 80% of your cholesterol comes from your liver, is synthesized by your liver, about 20% from the, you know, from what you take. But again, there's quite a lot of variability in absorption of cholesterol amongst different patients. So if you've got, you know, a patient I had a couple of weeks ago, a lorry driver whose predominant diet is Burger King and McDonald's, him changing his diet is going to have a huge impact on his cholesterol because it's an extreme diet and it's, you know, extremely fatty. But if you've got a patient who's already got a moderate diet, changing it isn't going to have too much of an impact. And patients are often really disappointed because they've tried really hard for 3 months to avoid statins and other medicines, but actually the diet doesn't have too much impact. So I think it's part of the solution, but it's often not, you know, the only thing that's going to help you. And often patients need extra help with medicines as well. Okay. Oh, fantastic. So Karim's put up the QR code for the feedback form. And so if you click on there, you should get the feedback form, and hopefully will we email certificates, Karim? Or? Amazing. Okay, fantastic.